Um, good morning, good morning, good morning. Uh, did you want to start, Miss Campbell, or you saying you want to take care of the baby? I came in late.
Oh, actually, Dr. Giddens,
You got this thing,
Dr.
okay?
Giddens, would you like to introduce Dr. Burden? Because I know you guys have you know, a
Sure,
really good rapport.
sure. No problem at all. Good morning, all you CAU scholars and candidates for graduation May 18th, 2024. Wow, wow. I realized that the conversation we had last time about your reflections, I made an error. I don't know why I thought I had already read you all's reflections. But when I looked at everything last night, because I told Ms. Campbell I thought I had a few I had to do them all. Thank you so much for the detailed reflections you offered. I was like all into it. I know you saw my comment, like she making too many comments. I was just really just floored by some of the comments you all made and how detailed are using this information. Thank you, thank you, thank you. You all are just awesome, awesome. Let me tell you about our speaker today. He is a man of worth, integrity. He is just simply magnificent. I met him about 4 or 5 years ago, Dr. Burden now. And he has a wonderful family, 2 children, a wonderful wife, who's also in the mental health profession as well. They both are authors. They both are university higher ed professors. He has been a professor in our department before. He's been an adjunct professor in our department on the clinical mental health side. Um, he's very hard working in his church. I think he's a deacon in his church. Uh,
Yes.
okay, Bible study leader, that kind of thing. Um, he's this sort of black male that you don't see on the news, on especially the weekend news. He's contrary to that news report you often see. So I'm so proud to have him with us this morning. Um, he again, he's on the clinical mental health side, but what struck me most about him when he interviewed for one of our positions is that he works um time he was with us at the Atlanta City Jail. And I never think about a prison. I knew prisons had some kind of counseling, but I never thought about the city jail because that's very different from the prison. And I'm like, they need counseling? I mean, it was just like something I never really thought about. So that was my lack of understanding and immaturity. We all are growing, right? So when he told me the kinds of work that he was doing, I was like, oh my God, this is amazing. And so when Ms. Campbell came to me about inviting him, I'm like, that is on point. I think he has so much to speak in this space. I would be very delighted for you to invite him out. And so that's who you have. I let him tell his story. I don't want to tell his whole story, but I think you'd be really amazed and a bit entertained about his story and the work that he does in a very sometimes dangerous environment, concerning environment. Everybody's not built to be counseling in that environment. It's such a very high volatile environment that when I reached out to ask if they will host an intern, it was like, we don't do interns here. It is too volatile. So I present to you Dr. Andre Burden. Dr. Burden, the floor is yours.
Thank you. Just want to just thank the program for inviting me here today. When I heard the idea from Dr. We were just talking about him, who had the
Shell.
yeah, Dr. Shell. I was like, that's an excellent idea, when talking about merging social work and mental health counseling, because we work side by side in the field, in every occupation, whether you go to CHOA, Children's Healthcare of Atlanta, at the jail, just community agencies. You're going to see licensed clinical social workers and licensed professional counselors working, side by side. And so when I heard the idea and the grant, I was like, this is an excellent idea. And this was something that he was very proud of. Um, and he laid the foundation, and you guys are still carrying that on here today. And I'm sure he'll be proud and to hear my report when I go back and tell him that I spoke. Um, just a little bit about myself. I've had a PowerPoint. Let me see if I can pull it up. Uh, I should have had that ready already, but
It's all good.
then I hear running my mouth. That's all.
Speaking good stuff, my friend. We're excited. We love Dr. Shell. We are so excited. This is our third cohort. So we hope we're getting better and better with each year. So.
Okay. And this is the third cohort. Okay.
We actually are blessed that we have an intern that was in our last year's cohort, and then our interns from last year are actually in our cohort this year. So we fully blessed.
Well, before we start, I want to do a quick exercise. If anyone's had my class before, I like to kind of start off with like some breathing techniques. It's 9:30 in the morning. We're in this Zoom environment. I just want to just help us settle in a little bit. So I wanted to share, just do a square breathing activity. This is something I utilize a lot with my clients in the jail, is teaching them square breathing and other little techniques that I'll talk about later to kind of give them some tools while in that cell. It's hard. We usually have our coping mechanisms of going out and taking a walk, or riding a bike, or going to visit a friend. Well, unfortunately, they're in an environment where they can't do those things readily. So you have to be kind of creative with some of the exercises that you give them, in order to help appease anxiety or to help them cope. So I'm gonna give you an example of one of the exercises that I might show in that environment. It's called square breathing. The idea behind square breathing is just trying to engage with your breath. Um, it's square because you're going to inhale for 4 seconds in the nose. You're going to hold the breath for 4 seconds with a full lung, and then you exhale out of the nose for 4 seconds, and then hold an empty lung after that exhale for 4 seconds. So that's the 4 times 4 times 4 times 4 breathing. Real easy to kind of implement or explain to your clients, and it's very helpful in kind of calming and helping you relax and enjoying your breath. So we're going to do that for about 3 minutes, and then we'll jump into me telling you more about my experience in the jails. So just follow along if you can. That's a little quick example of, just how to control your breath. Breath is one of those autonomic functions that we don't really think about much until we need it. And we realize that we're short of breath, or we can't relax, we can't calm down. And so the longer your breaths, the easier it is for you to calm down. So you can do that 6 times 6 times 6 times 6. Inhale for 6, exhale for 6 or 5. And if you want to excite, you feel yourself kind of drowsy in the morning, you can do it short, 2 times 2 times 2, to kind of excite your nervous system. But that's just something to kind of help us calm down and get into this moment. I'm Dr. Burden. Like Dr. Giddens was saying, I got my start in teaching at Clark Atlanta. I was, privileged to have taught a couple of students here, like Nelson and Brittany, and I see a couple of other faces in here Katie, that I've taught before. And the experience is something I probably took for granted. I didn't realize what I had when here, because the discussions here were so riveting, and so rich, especially in classes like multiculturalism. Um, the students spoke freely and openly and with so much passion. And a lot of times when you go to the PWIs, you don't get, that disclosure as much. And it's something I was really like torn about. Like, yeah, wow, when it comes down to race issues or things of that nature, is very quiet. It's crickets in the class. So I often find myself talking a lot, and almost being the Black voice, or the representative of the Black voice in that arena, when that's not fair for me to have to represent the whole culture. Um, but yeah, I went to HBCU myself. I went to Morehouse College, um, and got my doctorate from Argosy University. Um, I also met my wife there in the library, which was pretty cool. We have 2 kids, and they're growing and extremely fast. These you just thinking like, oh my God, these kids can be overwhelming, but it flies by. So I need to learn how to cherish these moments while I can before they're up and out of here and going to college themselves. But yeah, I've been a licensed professional counselor here in Georgia for over a decade now. And I have experienced that, first, when I started out, most like most people, doing a community agencies, going out in the community, door to door, using up gas in my car, and um, counseling kids in their, in the living room, you know, while mom's cooking, So just learning how to navigate that space was something that I did in my early years as a counselor. Um, really learned about like the disparities within, a lot of African American homes. It was a lot of single mothers that I was attending to, and I had to establish boundaries there. Sometimes, they would, some of the mothers will. You're going to them every day, talking to them about their child and their kid, and sometimes you're there 2 times a week, and it's like, okay, well, this is not just their counselor coming over. And I was like, no, I'm coming to see your kid. It didn't happen often, but sometimes though they would want to try to cross the line and want to serve you dinner and different things like that. And it's like, no, I just want to do my job. But no, it just more so it spoke to just like that. It was a gap, I was saying, or a disparity within our community in terms of having a intact family. And working with the jail kind of shed some light into why. Um, before I went to the jail, I then went to substance abuse at an opiate clinic. I was like, probably for the wrong reasons. I just got tired of putting all those miles on my car going door to door. but I got in at New Day Treatment Center and was fighting against the opioid addiction epidemic. A lot of people who were on pain medications. It all started from when counseling the people. It started from very honest, I got in a car accident, or I had a back injury. Just real honest places. And then, the pain persisted. They couldn't afford the medication. And so they got on the next best thing, which was heroin and, other opioids. And it's just a real terrible um, addiction, being that, it took a physiological toll on you. You couldn't just stop it because you thought it was the best thing to do. You really had to use the methadone, and then methadone itself could be addictive. So you had to titrate people off the methadone after giving them the treatment. And it was a hard environment to work in because you couldn't counsel them, you know, prior to them getting their dosage for the week. So you'll be sitting there talking to someone who's pretty much fiending, you know, for their shot. They couldn't sit still, they couldn't focus, they couldn't concentrate. And trying to do talk therapy was almost impossible until they got their dosage. And you had some that was committed enough to stay around after the dosage and participate in counseling, but for the most part, a lot of them would get their dosage and leave. Um, After a while, it felt like I was doing legal drug dealing. To be honest, I wasn't a fan of methadone treatment or Suboxone treatment, and the opportunity at Fulton County presented itself, and um, I guess the rest was history in that regard. I really enjoy, working in the jail environment, but it's something to you really have to, like Dr. Gibbs will say, is I don't know if it's for everyone, but it's an environment where I felt so much gratification. I felt gratification in substance use too, because when you saw someone making those changes, when you saw someone committed to the program and whatnot, you could see a new person kind of emerge. And the same thing kind of happens in a jail environment. Once you get a breakthrough, you can kind of see a new person emerge with new ideas, new perspectives, and just kind of a new motivation, a new direction in which they want to take their life. Let's see, can I share this? So that's a little bit about me. I'm a clinical supervisor, through NBCC. I want to grow my practice big enough one day, and this is my prayer, that I can have interns come and practice under me, and I can provide the supervision to them and things of that nature. Um, that's my aspiration. So within the next 5 or so years, I want to grow to a point that I can do that. I have a contract right now with Coweta County Sheriff's Department. Um, Pretty nice contract. Is They want 12 hours a week. So I go down there 2 times a week, 6 days. And it's not bad. It pays pretty well, and it's something that I can do kind of on the side of teaching. I'm a full-time assistant professor at Colorado Christian University. And but this is something I can do on the side as I grow my own business, so I don't be so dependent on colleges and university. At some point in my career, I can pick and choose my places. Um, but yeah, I would love to get tenure somewhere too. That's another thing. I'm digressing here, but Yeah, the Coweta County and Fulton County. And Fulton was the first one that I worked. Um, I know you probably heard the stories of Rice Street on the news. You know, they had a gentleman who passed from bed bugs and just kind of neglect, you know, and I didn't understand how could that happen because when I was there, I worked in what they call 3 North. And every day they would have a clinician, you know, it was me at the time who would walk around and look in each door and get like a status check on each person that was there, you know, see how they're doing, are they eating, are they taking their medication, a real status check of rounds. And then I would have a caseload of certain people I would actually call out of the cell and attend to them. You know, for somebody to sit in there and just be eating up my bed bugs, I don't understand what was going on. You know, fortunately, that didn't occur during my tenure there, you know, because I'm sure a lot of people are having to answer what happened, what didn't go right, you know, and there may be criminal charges and all kind of things, licenses revoked for that type of neglect to a client. And that's how I always refer to the guys as clients, not inmate, you know. I always refer to them as clients. That's how I saw them. Um, and I was there when they did 60 Days In. I don't know if you've seen 60 Days In. Um, that I want to say it was the Hallmark Channel, History Channel showed it. I was there when the BLM, Black Lives Matter, protesters were being arrested and bail was being paid for them to be released. I was there when COVID first hit, you know, and everybody was scared because we were like sitting ducks. Everybody in there thought we were going to get COVID. It was just, how could you avoid it? Everybody just sitting in there in a locked space like that. But, you know, by the grace of God, I haven't been infected by COVID yet. You know, I know that's not everybody's story, but he covered me in that moment. Um, but yeah, it was a very unique experience there. Like I said, I worked 3 North where I would have to do the rounds. I also worked in the clinic area. And so if guys were, you know, feeling a little off or the officers saw that the client wasn't being themselves, they would bring them to the clinic. And I will have to assess whether, you know, they were suicidal. You know, so I will often use the acronym IS Path One. I'm pretty sure you've heard of it before, but it's a quick suicide assessment that I will determine the ideations, well, it wasn't really substance use in there because you were inside the jail, but the depression, worthlessness, things of that nature that they may be experiencing, I will determine whether it was acute enough to be held on suicide watch. And that's when we will take away their clothes and anything that they can tie up or harm themselves with and put them in what this green smock that they have to wear. I would determine if they was suicidal, or award a psych ops or psychiatric observation. So maybe they had a mental health illness and they didn't take or have any medication, you know, or they were on medication, but since they've been in the jail, they haven't been bridged from the outside services, you know. So I will determine that if they need a psych observation and did they need to see the psychiatrist or not. Then there were some who were just psychotic. You know, they couldn't be redirected. They didn't want to take any medicine. They didn't want to comply. They were having audio-visual hallucinations that could have been a threat of harm to themselves or others, and they need a high level of care. You know, and so in those instances, we'll do 1013 referrals. You know, to Georgia Regional or Grady Hospital and places like that. So that was when working the clinic. So it was like very much like a hospital. You know, Fulton have medical providers like NavCare, Corizon, CCS, Correct Care Solutions. They have mental health coordinator, they have doctors, they have nurses, they have psychiatrists. So it's like a little hospital in there. Coweta's not the same. They contract, like I said, I'm contracted there. They contract the doctor, dentist, nurses, but it's not a whole medical provider. And I see the perks of both. Um, because accounting, pays for a lot of the contracts directly, where NAFCare will get a large grant like a $2 million loan and then disseminate it out to the employees that they hire. And I can see the benefits of both, but I think when you work with contracted people, you can kind of get the best of, and really be selective about who you bring in to serve your population. Coweta is similar. One thing I saw at Fulton is, like I said, I saw the guys as my patients, as my clients. I had a lot of care and empathy for them. A lot of times the officers did it. So sometimes you might hear someone getting tased, getting cursed at, your mama should have swallowed you, just all kind of just nastiness going on from the officers to the inmates. And it just really just put you on alarm, like no wonder, there's no progress. No wonder there's no rehabilitation, because there's a lack of empathy from the guys who see them every day. And so while at Fulton, I started a program where I would train the officers on mental health care awareness. So I will go to the training facility on Camp Creek and host like a 2-day training seminar on just what is mental health, giving them a breakdown of disorders commonly seen like schizophrenia, bipolar disorder, depression, anxiety. And so they can have an understanding of what those ailments are and how to recognize it within the inmates there, or amongst my clients there. Also, I taught ISPATH form. I taught them to recognize symptoms of suicide when people might begin feeling suicidal, and kind of promoted a collaboration, interdiscipline relationship between the officers and the mental health staff and the medical staff, And you had some mental health staff that will go in high and mighty, like I got my degree, I have my master's degree, or I'm a doctor, and I don't need to talk to this correctional officer. Who are you to tell me about somebody's mental health? But not and neglecting the fact that, this person's been spending 12-hour, 16-hour days, shifts, or however long their shifts are with these people. We see them once a week, on our follow-up list. So they can tell me things about their behaviors and mannerisms and things that I don't have privy to, but you had some clinicians like ourselves who would go in there high and mighty, and neglect all that time that the officer has spent with that client on a day-to-day basis. They can understand, oh, he's yelling out now, or he's not coming out the cell, like he used to. Is something wrong? And you might need to check him out. I value that information, because that gives me some insight, that I wouldn't otherwise I wouldn't have. So,
Dr. Andrews, Dr. Burden, can you speak to maybe the average age range of the population you were serving? And can you give us some kind of idea? I know this might not be nice, but some kind of idea of the offenses
oh yeah,
that they may have had and that gets them into this jail?
question. And yeah, by all means, y'all, please speak out and ask a question as I'm going on here. So we don't have to have a big Q&A at the end. But yeah, the ages can range from 18 to mostly about 18 to like 40, in that range. You may have an older gentleman or woman come in periodically that's in their 60s, and you got no business being here. But sometimes it's hard to teach new tricks. So you may have an occasional elderly person come in. But for the most part, around 18, very young, to about 30, 40. And the thing is, Dr. Giddens, a lot of times it's the first time that they've ever, when they engage with us, it's the first time they've ever engaged with a counselor. So, I have this person here who's saying he's just here to listen to me, just to hear my problems, hear my story. You don't want to give your opinion about me. It's non-judgmental. Like, what does that mean? So going in there with an open mind and an open heart and talking to these people, the inmates, you'll realize that they've never really engaged. A lot of times they've dropped out of school in the 6th grade. So lack of education, can barely read the forms that you're asking them to sign. Um, Broken families, sometimes they don't have families at all. So a lot of times jails kind of turn into gatekeepers, you know, for the community, because we're the first to pick up on things. First to identify whether somebody had HIV/AIDS or not. Fulton County Jail received an award for identifying the most HIV positive persons in the Atlanta area. Because a lot of people didn't know. You know, First time identifying whether there was domestic violence in the home, or if there were educational deficits. Like I said, a number of the people I would interview, it became commonplace for someone to say, I went to the 6th or the 8th grade, and that was it. You know, Homelessness, you know, children homelessness is just as bad as adult homelessness nowadays here in Atlanta. And that's evidenced by just going downtown. You can see the tents and the homeless communities that are just prevalent here in Atlanta, under the bridge, abandoned homes. Mental illness, undiagnosed mental illness, just people who have lived a life, with audio and visual hallucinations and have never had it attended to. And it's just commonplace to talk to somebody that's not there, or hear a voice that's commanding them to do this and that. Instead, substance abuse, so many people, and I think the legalization of marijuana, but so many people, quote unquote, self-medicate. It helps with my depression, or when I'm feeling down, or it helps me go to sleep. you know, and really it's undiagnosed substance abuse.
Katie asks,
Um,
what is the most effective theoretical orientation or approach that you have used in this space?
yeah, when I first got into the space, Dr. Sophia Henry, she was my supervisor, and she was like, "We don't have 45 minutes. We can't do a full counseling session in here, you know. But if you approach your clients as if you have 45 minutes, they'll tell you everything you need to know in 5." And that kind of stuck with me. Um, I tend to use like a solution focused brief therapy, where, and I'll talk about it a little later, but where where you try to understand the problem and then you try to find solutions quickly. Um, you definitely have to have a person-centered, integrated person-centered approach, because you want to get the client's perspective. You want to understand their story, um, understand some of the whys in their behavior. So when you understand those whys, like I said, solution focus approach can kind of help kind of do some problem solving and kind of redirect a little bit. It's good that if you're going to be in this environment, that at some point you take a CEU of advanced course in trauma. So being trauma informed, I think, is very important because a lot of people in this environment have experienced trauma of some sort, whether it's neglect, abuse, just violence, witnessing that. You have a lot of recidivist people who have gone to prison, and some of the horrors that you can hear someone tell from a prison experience. It similar to war when dealing with like a veteran population. So I guess being trauma informed, solution focused, brief therapy, I think works in individual or person centered counseling works a lot. I like Adlerian, um, but that's what clients who you really establish rapport with, who will be willing to talk about their family and some of their interpersonal connections. Because I don't think we exist in a vacuum. So to kind of understand their family, their relationship to family, especially if there's drug use, um, incarceration, which, of course they're in, that can cause a rift in a lot of relationships. So a lot of people are feeling alone and neglected, especially a lot of the young guys. Like, I thought he was going to put money on my books, or I thought he was down. And they realized that once you get in there, that dude that said he's your family, not sending you a dime, you know. So that reality therapy is good there too, to kind of have them weigh, okay, this is what you thought might happen, and this is what's happening, and how is that making you feel to know that this guy that was preaching you that you're his family now wants you to take his charge and not giving you any money on your books. Our young kids have such a loyalty to like unwritten codes, like I'm not going to snitch, and I'm not going to sell out, or this, that, and the other. And it's just sad. Like, you're going to just take a 20-year charge because you don't want to tell the truth, who really did it. You know, I don't understand it.
Okay, so Michelle wants to know, have you ever been called into court on behalf of a client?
Haven't. And I think it goes back to what, Ms. Henry told me at the beginning. We're not really there to discuss their case. Now, I do know I don't like to go into the session blind. So we have access to their records, what they're charged with, and things of that nature. But unless they offer it, I rarely go into the session trying to understand their motives. Why did you do this, or why didn't you do that? I'm not the investigator. And that's what helps establish the rapport as well, because this is a person that's here not to judge me or question me or investigate, but he's just here to hear and listen and help. So when it's said that jail is a dangerous environment, on the surface it could be. You just don't want to be walking around there willy-nilly. But when they know that, oh, that's Dr. Burden, he's here to help. He's the one that talks to me about my mental health and, how am I doing? They're happy to see that. They're happy to see me. I'm also like a way out of that cell, where a lot of times they're locked up 23-1, which means they're in there 23 hours and they come out for 1 hour watching TV or walking around. So for me to come out and say, hey, come out here and talk to me for 20, 25 minutes, they jump at it. And when I first got there, I would see guys come like this, and you'll have some officers who, if they were afraid of that person was, irate, they wouldn't take the cuffs off. So that was kind of something for me psychologically, to try to counsel somebody who had handcuffs on. And I will always ask the officer, can you just take them off? It's just, and they would, for the most part, take them off. But then some of them just like, no, he's been doing too much. And you just have to deal with it, you know. But no, I've never been called into court, thank God, because I don't have anything to tell them outside of, just their gains, um, psychologically. Um, but I don't have anything to contribute in terms of their criminal charges.
Thank you.
Yeah, this picture that we're looking at here, the history of mental health care in the jail, a lot of people believe that it was when the deinstitutionalization of psychiatric hospitals, long-term mental health, long-term stays, when they were closed down, the asylums is when the increase of mental health patients in the jail began. Um, a lot of community agencies were overburdened at that point after the deinstitutionalization of the asylums and long-term stay. And so once the community agencies were filled to the brim, the leftovers were homeless. They were getting arrested for small and petty crimes, and they were coming to jail. A lot of self-medicating is what a lot of term you hear a lot in the jail when people who can't afford medication, this was their way to cope. So the jail became overrun. And when I was working at Fulton County, the numbers were probably still the same. Fulton County Jail was the number one healthcare provider in the Southeast United States. Just to give you an idea of how many inmates suffer from mental illness. 2 million people with mental illness are put in the jail each year. And 15% of the men have mental illness who are booked, and 30% of the women. And we make up 60% of the prison population. So it's a lot of us. And that was something when I went to Fulton County that I had to, like, in terms of like self-care, and I'll talk about self-care a little later. I had to really kind of get over is that, these are my brothers, man. These are, guys I probably could have went to school with, or, grew up right beside, and to see 12 of them being led down the aisle by this one officer, all connected to each other in chains. I guess my ancestry memory was taking me back. This is how slavery could have been, you know. Um, very, it was very disturbing when, to first get in that environment and see that. So counseling in the jail setting, just to kind of to go into that, like I say, you always have that officer present, so if anything, if you ever got irate, if you started getting too loud, the officer would always step in. And I've had sessions where the officer would end it. Like you're talking too loud and you're not able to be redirected. We're just going to take you back to the cell, and but the officer's always present. The medical staff is there, so you have doctors. And, can you tell me what's going on with him physiologically? He's saying that this is happening. So I'm always just kind of talking to the doctors about, just some of the health concerns that guys might tell me. And I'm not a doctor, but I can definitely relay the message, and I'll go in and talk about them. But like I said, I was never fearful in that environment. First of all, I'm not going to be a victim. Not saying that I'm the toughest person in the world, but I'm not going to be anybody's victim. So if they jumped over here, that I'm not just going to get beat up in there. But fortunately, I've never had to kind of test that theory. No one never really tried me like that. Like I said, there's been times it's just been me and the inmate or the client in there, and the officer walks off, because the officer can see that we have a rapport and the guy's talking to me. It's like, wow, you know. And so I don't have a lot of times I didn't even have the officer present. I wouldn't advise that for a new clinician, but um yeah, you can get comfortable in there in a good way, not necessarily like you're letting your guard down, but it's after a while you get used to it and they get used to you. They're huge caseloads when counseling in the jail population. In private practice, you know, someone who has 12 to 15 clients, that's a busy practice, you know, but you can easily have 40 to 50 people on your caseload at the jail. Not saying that you're going to see all 40 or 50 once a week. You know, some may be 2 weeks, some may be every 3 weeks. It's according to their need. Um, is when you'll see them. Most of the time, the paperwork is done due. Most of the time, the paperwork is due at the end of the day because you're working in an environment where everybody sees um, the data, the doctors, the psychiatrists, the nurses. You know, so if they want to check and see what the person's mental health status is like, you need to have your documentation in so that they can, you know, look at that and say, okay, this is what's going on. And that's probably the same at some of your sites. And I know, you know, when I work at the Children's Hospital, they're the same way. They use Epic, and they want you to have your notes in because the doctors and other professionals are going to be looking at that information. Um, and you have to understand that you're in the officer's world, you know. So there's a lot of times I have my case, I have my clients that who I want to see, and I'm going to the floor like, oh yeah, can you send me this, you know, A, B, and C clients? And they're like, no, we're on lockdown today, you know. Or we're doing a random check of their cell to see if anybody has any kind of paraphernalia or this, that, and the other, and we're not bringing clients today. Okay. You know, I'm not arguing. We're in your house. You know, that's how I always, so I'm in your house. I'm a guest in your house. You know, so if for some reason they're not getting clients that day or they're not pulling clients or they're doing a search, you know, what can you do? You go back to your office, right? And so there are times when you go in a jail setting where your whole caseload or your whole day is canceled because they're not pulling the clients that day. A lot of people say you shouldn't shake the client's hand after the session for fear that they might shake it and pull you over and do something to you. I wasn't that concerned about, you know, my clients' behaviors. They're told not to reach out to shake your hand afterwards, but you know, sometimes they may miss the memo and do it, or you know. So my thing with you know, that was something I do a lot. Is just adapt, you know, the fist bump or something. And then the other time I would, you know, but I didn't hug, I didn't do the bro hug or anything like that. I would do the handshake, but that was the fear. You didn't want anybody to pull you in or take advantage of you in that regard. Um, yeah. So like Dr. Gideon was asking, what are some mental health techniques or theoretical frameworks that you use? Solution focused brief therapy was the one that primarily worked for me, or primarily works for me. So you'll have problem talk and you'll have solutions talk. And that problem talk typically comes in at the beginning. That's that first session when they're talking about their problems, you know, what isn't working, you know, what's wrong, blaming folks, not really wanting to take any kind of accountability. That's in the problems talk. But then at some point you want to move towards solutions talk. What's working? What are some of your strengths? You know, asking them about actions towards their future. What can you do differently? Suspending judgment, you know, let's just be neutral here and talk about this. Um, And I think once you get people to a change growth mindset, with solution talk, I think that's when the real change can occur. Um, you have to get them to get some radical acceptance that this change, you know, may have to be done while serving a sentence, while you're, you know, paying for the crimes that you committed when you were in that other mind state. But it has to start somewhere, why not now? So I'm always a proponent of the here and now, working on what can you do right now in this moment to kind of change your mind state in your situation. CBT is another one that works in here too. Like I think CBT, and that's cognitive behavioral therapy, where those cognitions. Sometimes our clients can get caught in a negative trap, where they wake up with negative thoughts and they tend to have negative actions. Oh, this is a bad day. So they mope around. Um, they start feeling bad. I don't want to do this. And so the behaviors is affected by that thought that it's a bad day. So I'm not going to call my friend. I'm not going to go to the gym like I tend to do, And so they're stuck in this negative trap where if you can kind of promote a healthy circle of, oh, this is a good day. I can do this. Let me try to submit my work. Let me try to apply for this job. Let me go take a walk. I feel better about myself. I feel more healthy. And it's just kind of a loop of just positivity. And so CBT is one of those things where you can identify, some of those negative cognitions that the client may be having and kind of get them to think more positively and in turn do more positive things. So CBT is something that's very effective. A lot of psychoeducation can go on with CBT as well.
Nelson has his hand up, Dr.
All
Burden.
right, Nelson. Sorry, I'm taking this off.
Good morning, Morehouse brother, Dr. Burden. So as we have discussed in the past, and with me embracing existential, wanting to be my framework to be in existential therapy, and now that I'm getting ready to graduate and I'm really owning that process of learning that, how would you, or does existential therapy even serve well as it relates to a prison population? Because, we understand the existential approach is the will to live. It's the will to want to be, it's the will of the why, things that are deeper. Are they even able to reach that level in a prison setting for that type of in-depth counseling? And if so, does it help to create change in the environment that they're in? Because I know I don't have the bravery for the incarcerated population. However, I am working in a space where we have kids that were once incarcerated or once thrown into a residential facility. And so I found when I apply my existential techniques, it does help. But of course, the situation is different. So what are your thoughts on that?
Like I said, with suicidal clients, by all means, if you have an existential approach to kind of give them some meaning or want for life, I think that can be very effective. And they have nothing but time. A lot of times with existential therapy, you want the client to go back and do some kind of introspection and thinking. And that's exactly what they have time and space to do, is to think about exactly what you just talked about in a session with them. So, yeah, I think existential could be very effective in that environment, but I don't know how, I don't know how it will affect the whole. I don't see how, existential could affect the whole. If you were to do like in a group setting, I'm trying to see how. I don't see how it could. It could, if you can get a bunch of people thinking about the same things and ideas, it could kind of spread. Um, a lot of times with CBT, it's a lot of psychoeducation, so it's easy for that to kind of spread because they can teach somebody else. If you teach a breathing technique, they can teach somebody else, but existential is more, I think, is more individual, their individual meaning or search in life. So I don't see how that can kind of catch on throughout the place. but it could, you know. But so I think your efforts would be a lot in terms of one-on-one, unless you were creative enough to come up with an existential group. I think that could be effective.
Thank you, sir.
Mm-hmm.
We have another question. If the client does not have a formal diagnosis, do you ever make a diagnosis based off one visit?
No, I don't think one visit is enough to make a diagnosis. I think a big problem in our community is overdiagnosing, anyway, or premature diagnosing someone based off of one experience, especially in a jail setting. You know, you, you could probably diagnose everybody in there with generalized anxiety disorder if you just wanted to, if you're quick to diagnose someone. But you have to take in consideration the setting, um, the change. You know, if you just have to do it for billing purposes, the safest thing to do is to do adjustment disorder, adjusting to this new environment where you're told when to eat, sleep, when you can come out, you know, get up, tell us your number, just want to make sure you're in the room. You know, so adjustment disorder is probably what you can probably classify everybody as initially, but um I to be determined is what I often put after the first session or two, because sometimes you just don't know. You don't know the client well enough to make a diagnosis, because some of those diagnoses can follow people, and you don't want that. You don't want to label someone, you know, based on the experience when they're probably at their lowest.
Mhm. Is there a set number of sessions that you have for the inmates, and how do you determine when they've had enough sessions?
Yeah, and this setting there is a set amount. You know, you can see them as often as you feel they need. If they're very acute, you know, you can see them twice a week. Um, but if they don't, a lot of times they want you to see patients who are on medication. But a lot of times when they're on medication, they're very stable and they don't really need engagement. So you would just see that person once a month just to kind of do a status check. Is the medication still effective? Are you taking it? Any needs? It's like a wellness check, you know, just kind of check and see how they're doing. But others you need, you know, may need more attention, and you can see them as many times as you want, you know.
Thank you.
Right? So like I said, the types of services, this is the green smock I was referring to earlier. This is when someone has identified that they're suicidal. They want to hurt themselves. And you'll have young kids. I know at Fulton County, there were a lot of young people who knew this was a way I could go down to the clinic. The clinic is like a hospital, it's the closest they can get to the outside world. And so they will fake it. But a lot of executed suicides were ones that guys were playing around. You know, so we take it all serious. Whether you know that joke, he's just being a joker, you know, you take him serious anyway. And this green smock, typically they don't have anything on here. Sometimes they may have a t-shirt or underwear under there, but they're in this until you can determine whether or not they're out of that state. You know, whether they have they're future oriented. Like they start talking about things like, oh, when I get out, I'm gonna spend more time with my kids, or I want to go to treatment and get into some meetings. That's future oriented. That's outside of, okay, he doesn't want to kill himself anymore. He's now talking about, you know, going to meetings. He's now talking about going with his family, what he's going to do when he get out of here. So that's some future orientation. So that's a sign that he may be coming out of that funk. When there's a change in his or her thoughts and feelings on Mr. Page. You know, I don't want to do that. I was just in a bad place. You can kind of hear the remorse. That might be a sign they're ready to come off a suicide watch. If they start saying, you know, I won't kill myself because, you know, I'm gonna go to hell. I don't want to go to hell. that could be a sign. Religiosity is a big prohibitor of someone following through with a plan. So if you can hear them say something like, "Oh, I was told if you do this, you'll go," that's another sign that okay, they might be coming out of it. Psychiatric observation is another one. Like I said, that's when the person who may be psychotic and needs some stabilization. Whether it's medication. I got a red mark on my screen. I have a red pen. I think I'm gonna mess up my screen. Anyway, um, they have they're having audio visual hallucinations. Um, maybe you can see them responding to internal stimuli, like maybe moving their lips, and no one's talking to them. So if you see someone responding to internal stimuli or just very tangential conversation going from here to there, they're not making any sense, it's not logical, that person may be a good candidate for psychiatric observation. And there they can keep their clothes. They're not necessarily tied to the chair like this gentleman's being tied in the picture, but they can, they're like pleasantly psychotic. We might hold them for a little while until we can have the psychiatrist look at them and assess whether there's medication needs, or try to identify their baseline and determine which floor we're going to put them on. Or we're going to put them on 3 North, where the acute populations, or B1 at Cowetus, put them in that area where the acute mental health candidates would go, or could they be amongst general population, with their condition, in their condition. And then, of course, this is a 1013 form. And here in Georgia, this is where non-voluntary hospitalization occurs. So at some of your sites, you may have seen this form where someone needs a high level of care, and you'll fill out the 1013 form. And as a LPC or a licensed clinical social worker, you have the authority to complete a 1013 form and have someone hospitalized. It's a disciplinary approach. I think this speaks to what this whole program is about, being able to work with other disciplines, whether it's behavioral health, social services, food and nutrition. I advise everyone, LCSW, the LPCs alike, to develop a reference book of different referral sources within the community. Everyone should have connection to different food banks, shelters, AA meetings, psychiatrists, housing programs, whatever it is that you can come up with. As a clinician, you should have those things at your disposal for the clients that you serve. I always think about Maslow's hierarchy of needs. And if you have a client that's hungry or don't have a place to stay, that can really affect their mental health. It's hard to kind of get past the fact that I'm just hungry, really, before you can go to any kind of self-actualization and goal setting and things of that nature. You need to understand, okay, is there food on the table? Do they have a place to stay? How is transportation? You want them to come to your office once a week, but they can't afford it. Will Zoom be a better option for them? Considering they even have the internet. So financial. So all these things are interconnected. Medical. What's going on with them physically? Is that why they're acting the way they're acting or behaving? Is it anything that's related to their health? Not only should we integrate with other disciplines, we should also think about legislation. I think that's where change really occurs. So just last week they had LPC week and LPC day at the on the steps of the Capitol building. You know, where a lot of counselors were there advocating for the profession there on the steps. A new bill just passed, or is we're waiting to see whether Governor Kemp signs it or not. It's called Senate Bill 63. And this is where there's like 30 new crimes that you can only get a cash bond to get out of jail. You know, and you can't bond someone out more than 3 times a year, more than 3 persons per year with this new bond, with this new bill. And you know, that kind of works against like churches and other organizations who like during the BLM movement will come in and bail people out for protesting. You can't do that under this new law. You can only bail out 3 people, you know. It's all, I think the bill, it has potential to aggravate the county jail system because you're going to have people who can't afford the cash to get out on things. And so people who are there for traffic violations or criminal trespassing may be there months on end because they can't afford a cash bond. So a lot of things are happening right under our nose, and we need to kind of be aware of some of these things. So in legislation, that's one way that we can be advocates for the clients that we're to serve. Self-care. It could be stressful. Like I said, there were times where I just had to just leave and go take a walk after you hear the taser gun going off. And you hear somebody screaming from that, or you hear the cells just slamming behind you. Or just hearing the trauma over and over and over again with each client that you serve. It could cause vicarious trauma. It can cause empathy fatigue. Like, oh, I've heard it before, you know. And this guy's just telling me how he just witnessed a murder or whatever, and it's just rolling off my back like he, you know, told me to score the game. And so at those points, you just have to realize that I need to take care of myself, you know, mentally. I think all counselors, LCSWs, I think we should seek counselors, you know. Even if it's twice a month or once a month, you should talk to a counselor, especially when you're in a very acute trauma situation like in the jails or at a hospital or just the profession itself. I think we should, you know, really take care of our mental health. Self-care could be balancing your checkbook. A lot of times we graduate from these programs and we want to save the world and we want to help everybody, but we don't have any kind of financial health. Price shaming is something that we'll often get into, you know, as clinicians. Oh, I'll give you to it for $30 a session, $40. I know you can't afford it, you know, but when you're really worth $125, $150 a session, you know, you don't have people question the dentist when they get the bill. Why are they questioning you? You know, so understanding your worth, that's a part of financial self-care. Balancing your checkbook, you know, making sure your funds and things are in order. Self-care isn't always laying on the beach, you know, but it can be actually like taking care of things that's going to keep you secure long term. Making sure your environment is good, you know. We're seeing so many effects of environmental, like global warming, like California. You know, God bless those people over there. You know, the freeze we just had here. You know, whatever you can do to kind of help. Gardening is one good way to kind of get out with the environment. Intellectual, don't let all of your reading just revolve around schoolwork. try to pick up a novel or a biography. If you like reading, autobiographies, I like reading autobiographies. Pick up a book that you just want to read for leisure. Don't forget about that, you know. Spiritual, keep God involved. Um, I don't know how I would have made it through graduate school without, that connection with the creator and understanding what it is that he had me to do. Because a lot of times we don't know exactly, so letting him kind of order your steps and that friends, social, you know, don't forget about them. I know you've been very busy and it's kind of difficult to kind of find times to hang out, but you make time for what you really care about. And I'm sure you care about your friends and family, so make time for them. Don't let it all be about work. And the physical, make sure you're eating right, exercising. We work in a very sedentary lifestyle where we're sitting down and talking to people essentially. So at some point you have to figure out, okay, well, I gotta move at some point because if you have a full day's caseload, that could be 6 hours of just sitting and talking with somebody. So find time to get you a mental, physical break where you take 20 minutes to walk, or after lunch or after a good healthy lunch, you know. You have to take care of yourself. All right. So one of my ideas that I want to do is what they call socio group therapy. This was what was done in Rwanda after the ethnic cleansing there. In Rwanda, 250,000 people were killed within a 5-day span. And how did the community heal itself after such an atrocity? And so what happened was counselors came in and social workers came in and started a program called socio group therapy. And so you will have perpetrators and victims alike in this one group, a 13-week group session. And afterwards, there were cohorts formed, working cohorts. They will farm together and build together. And the ironic thing is they didn't talk about the trauma until like week 8 or 9 of the 13-week group. In a westernized society, you would think that trauma would have been the first thing. What brought you to group? What brings you here today? When you do your mock sessions, what brings you here today? Why you come to see me? And the first thing they talk about is the trauma and the things that brought them there. But not in this group setting. There's this trust established first. There's camaraderie established. There's an understanding that, we're there to help. Rapport established before they delve into, their specific traumas. And so this is something that I feel that can be very effective in a jail setting as well. And that's one of my aspirations is to do socio group therapy at the jail I'm working at now at Kawita, to see if there can't be, any kind of camaraderie formed amongst inmates, trust, that they can begin to network and kind of depend on one another from a more Eastern point of view, opposed to everybody being in there for themselves. A lot of time in group work, you can still see people just kind of working on themselves and not really caring about the interest in the growth and development of the others. So this is something I want to try. They're expanding the jail down in Kawita, so this may be something I'll be able to utilize within a year or so. Recidivism. Georgia, there's about 323,000 arrests each year in Georgia, 323,000. And of that, the recidivism rate is 26%. 1 in 4 of those 323,000, which is about 84,000, are going to go right back in. This is very problematic, There are 9,000 prison workers, and I think that's over $1 billion in finances to pay them. And and operate the prison system over $1 billion each year that it costs the state. So there's 323,000, 30%, that 30% recidivism rate has been the average over the last 10 years. So it's just cycling people just in and out. This is a revolving door. And it's something we have to do something to kind of change that. That's what I wanted to do. I want to take about a 5-minute break. Let you guys just kind of process a little bit about what I've talked about. But then we're going to go into groups of 5. And I want you to discuss what other ideas, what can you do, whether it's on a prevention program or a program that you can try to implement in the jail that can kind of help stop recidivism or prevent, guys from being arrested, period. Some things people have said are drug diversion programs, residential drug and alcohol programs, supervised probation over jail time, house arrest, but what kind of ideas do you think we can implement or try to implement to kind of help recidivism? And just kind of give you 5 minutes to just kind of talk. Well, 5-minute break, and then you come back and we're going to break up into groups of 5 so you guys can discuss amongst yourself some innovative ways that you can attend to this population. All right. So 5 minutes, if we can come back at 10:55, we'll then break into our small groups. Okay.
Okay, everybody, take 5. John, you setting the rooms up? Okay, I figure you look so intense.
When I tell you nobody likes playing spades with me, because you already know I got books or I don't. Like it's all of my forehead. I
Okay.
think it might be exactly 5 though. Look at us. I think so. Yeah, so I tried to do a nice little mix.
So make sure all the school councils are not together.
Yeah, that's what I'm saying.
Okay, good.
I tried. Let me see. I haven't opened the rooms yet. We can open them when you want to come back from break, if that'll work, Dr. Burton.
Yeah.
Okay. Because you want to give them instructions before they go into the room, right?
Yeah, just simple. Just think of some ideas.
Okay.
And we need one person from each group to share.
Yeah, one group to share, what the group discussed. That's
One
good.
person to share.
Okay.
Mhm.
Very good. I'm gonna take me a 5-minute break too.
I was thinking the same
I
thing.
got 4 minutes now.
Okay. So we coming back at like 10:57, 11?
Yeah.
Okay. All right. We gave everybody till 11?
That's fine.
Okay. Okay. I think everybody is coming on back, but they seem like they are. I'm so excited about this informative and interesting conversation that I think definitely transcends for both counseling and social work. Because one thing that you said, Dr. Burden, that kind of resonated for me was that some people are saying that's their first counseling session, is that it's with you in prison. And it made me think, like, dang, if only they had one session before, what kind of skills could they have possibly had to kind of, realign that? So that was really significant, because I wonder how many people that's the first time somebody's actually tried to have a conversation with, to process your feelings. So, but, so not all my good work. Okay. Whew. Okay, it's there. All right. So I can open these rooms. Did you want to share the question again and then share a time frame, and I can put a timer up if you like?
Yeah, we can do 10 minutes.
Okay.
And you just discuss programs or ideas that you can have to better treat our inmate population or to help stop recidivism.
Okay.
Now, are we creating these programs, or are these programs that are already created?
You can be as creative as you like. And we're gonna have one person just kind of share what the group discussed when you come back.
Good question, Andrea. So I think you have options. You can think about reinventing something you've already heard of or starting from scratch. So I open the rooms, and then you can join them, right?
We'll come by and peep at you for a second.
And they're joining them now.
Okay. And then share it to me one more time and I can put it in a message, Dr. Burton. You said come up with some
Solutions to help stop recidivism or ways to better treat clients who are already incarcerated.
ways to help clients stop. I have come up with some solutions to help stop recidivism or ways to help clients
Currently incarcerated.
that
So
are
to stop recidivism would be like programs outside of the jail that they can come up with.
okay.
There's like
Or
other
ways to
ways to
help
help
clients
bother.
refrain from jail. I see.
Okay, yeah. So it can be preventative.
I see. Okay.
Or remedial.
All righty. And you said 10 minutes. So I think everybody's in their rooms, and now I'm gonna use my app. Timer. All right.
There's a way to put the time on here, but I don't know how to do that.
I put it up, but that's just showing it for me. Is it showing for,
Oh, it doesn't
does
show it to
everybody
me.
get it? Or is it
I
just
see
saying
it on here.
I'll see it up in the top corner of mine too.
you do?
Mhm.
Okay. There we go.
Good.
Zoom trainings.
Okay.
It's in I'm not sure if it's updated or not, Dr.
Why
Gibbs.
is Asia not in?
Oh, let me
Haven't
see.
joined yet. But what is she waiting on? If she hasn't joined the call.
uh, breakout rooms. Let me see which room I put her in. I said move to.
She's supposed to be in room 1.
Yeah,
It does say that. So
Asia, are you there?
I'm getting ready to call her.
yeah, she might not be on.
Might not be back yet.
It's not letting me move her to that room though.
And she gotta do it herself.
I see.
I'm trying to see if I have her phone number. Yeah, I got her phone number. Call her.
Okay. Okay.
John, did you go to Howard?
I did.
Okay.
I thought about changing, but I like all HBCUs. So so I had it on from early, but I did my MSW there. I did.
Awesome.
Yeah. But I've been at CAU since 2013. So I feel like I've been to 3 HBCUs, but I think I spent my longest time in CAU. So
She's in there now.
okay. But yeah, I like the AUC. Like when you mentioned Morehouse,
I'm gonna join in and see if anybody got any questions.
okay. Thanks, Dr. Guinness. We had a gentleman that came from Morehouse, and we've had a few young ladies that have come from Spelman, and it's always kind of sweet when we have other students that come from the AUC, especially from the sister colleges. But with our Morehouse guy in particular, like we don't have a lot of men in social work, and he really he got his barber license. And so,
Okay.
yeah, and so he does this therapy piece where he's cutting hair. He used to do a lot of free haircuts when he was in school. But I'm always intrigued with our Morehouse guys because I just find social work to be such a niche where we need Black men that are comfortable communicating and just so yeah. Yeah.
That's cool.
Yeah, I loved when I saw he because he was cutting hair. You know how similar you have like ladies that'll do hair, but they may not have the hair license and stuff. But he went and he got his actual hours as a barber, and I love where he's going with that. Like I follow him on Facebook a little bit. So yeah.
Yeah. Yeah, people open up a lot at the barbershop.
Right? Especially when I think about men.
Mm-hmm.
Right? Like that's like a safe place, you know? So I was like, wow, the barbershop is where it's at. And then I don't want my computer to die. In my I have a practice 2 class where we focus on groups and working with like moving beyond individual practice into like small groups, families, communities. And so in one of the assignments that we do, the students create a box. And so the outside of the box, they put like how they want to be seen. Like what are the things they want people to see about them? And inside are the things they might not feel that comfortable about. Like I shared with them, I used to smoke cigarettes. So like inside my box, it would be like a pack of cigarettes because I would go eons to find a safe place to smoke a cigarette. And I wasn't proud of it. I don't think that's the worst thing in the world, but it would be like my secret, right? Well, the students did their boxes last week, and a gentleman did his box, and he was saying how as a male, he felt like this was one of a really great opportunity, and he wondered how other many men would be comfortable with that type of activity where like you can choose what you want to share, but like there is something to how you want to be perceived and then how you have these internal feelings. And so he really got me thinking about, you know, just how different genders and people can see certain things. So yeah.
Yeah. Yeah, there's a big stigma with men in terms of mental health,
Right.
you know,
Yeah.
and opening up. And that was another thing about the jail, is that you had a lot of men who you don't talk about that, or you know.
They're
And so
uncomfortable with even the thought, right?
mm-hmm.
Yeah. Yeah. Yeah.
That's cool.
Yeah. Do you think it's different too when you bring different genders in? I worked with a program where we were trying to do prevention for sexual assault, but we had done some research and found that if we had sessions where they were either mixed or you had women, men didn't speak the same way as if you had a male facilitator and he was facilitating the conversation. Like men felt differently, or and the same with women. Like they may have shared differently with it not being a mixed room.
Makes
So
sense. So a
yeah.
lot of times that man could trigger, you know, a memory, or he reminds me of him, or
Yeah. Yeah.
some shame. Yeah.
Thanks for joining us on our Saturday morning session. I know it's a Saturday morning, but honestly, within the two programs and by the students doing their practicum, I'm sure you can imagine they don't really have a lot of time outside of the classroom to do some things. So with Dr. Giddens and I, you know, like you said, Dr. Shell, he really originated this and I was happy to be a part with him. But if we were to rewrite it again, I wonder if we could create the piece to include it in like a practicum class. You came in right on time, Dr. Giddens, because I was talking about like if we had the opportunity to rewrite it, because I was saying how we do these sessions on Saturday mornings. But if we could rewrite it, if we could, like instead of having the sessions like outside of class, like if we had them within class time. Like you have a seminar class, like we have a seminar class, and like we could do sessions there.
Can you put Aja back in her class?
Mm-hmm.
Reassign her. She got kicked out.
I am a 2, 1. There you go. Okay. Y'all have a seminar class, Dr. Giddings?
No,
No? Where do y'all discuss y'all's practicum experiences?
we have orientation sessions.
How often are they?
We have one prior to the orientation session for practicum.
Okay.
And then we have one prior to internship.
She's still not in their room.
She was, and I don't know how she came out.
But
I just saw her in there. I don't know what happened.
I wonder if she's got like bad reception.
Let me see. She was in the
It
first.
says not joined, but
She
I don't.
was in there. I just saw her in there.
Right.
And she got kicked out. I don't know.
Mm.
But she knows where she's supposed to be, so she could join in there herself.
Okay.
I don't know what's going on with her. She said something was going on with her daughter.
Okay. Yeah.
So yeah, we don't have a seminar standard class, but we just have a lot of professional development sessions.
Okay.
We consider that one.
But I guess that's what I'm saying. Like, see how you're saying y'all have those sessions? Like, if there was a way to incorporate it in what we already built in, you know what I mean? More so than like adding on. I just wonder if like, you know, as we think about rewriting it, if it's something that we wanted to add to, like, offer to everyone, and then you may have a select group that you have the stipend for, or that you require to do the reflections. You know what I mean? It's just something we got.
They get paid for this too, though, right?
They do.
Yeah. So the
10,000.
extra time probably is like, it's not too big of a deal because they
Right.
get paid.
That's a good point. That's a good point. Yeah. We do have a stipend. Way to bring it back. You're right, Dr. Burton. They got time.
Right.
Yeah.
Follow the dollar bill.
And not only that, they may not realize it's way down in the career, but this is very beneficial to them.
I think so.
They have no idea how much information is being poured into them.
I think it's really going to be like threaded through. Like I think it may not see it now, but I definitely think you'll see the opportunities. That's where I think the reflection papers really kind of come in handy with like, how do you see this with your practical? Yeah. Yeah. Yeah, they come back automatically, right?
Yeah, because your time should close, whatever time you put on it, it should close it out. And it sends them a warning that it's closing out.
Oh, see, I didn't know if, let me see, the breakout rooms. Let me see. I'm gonna
Say
close.
time's up.
Yeah.
Yeah,
So
it usually sends them a warning, you got 1 minute left, 30 seconds left, like that in the break room.
I didn't send a warning. Should I send it or should I automatically did it? I'm gonna
I,
send it.
I've never set up a break room, but I know I've seen them what it tells them.
I think I should have did that. I'm gonna close the rooms, bring them back.
Maybe
Hey,
it's closing, maybe it's doing it, maybe it did do it. I think
Yeah,
when
I
you set them
wonder
up,
that.
it asks you about the time, so it's doing it.
hey, I'm down with it.
If not, I just close them out.
Oh, there we go. Here we go. All right.
Yeah, see, our break rooms were closing in 43 seconds.
All righty. So I think everyone is, well, slowly. So we got 17. I think we got 25 total. So they're
So,
coming.
excuse me, y'all. I wanted to, while we have Dr. Burden here, this is fantastic because for the American Counseling Association, the free CEU of the month is an article based on, let me go to the top of this, African-centered therapeutic community substance treatment, substance abuse treatment with incarcerated Black males, a pilot model.
Wow.
It's a free CEU. I think everyone should download it. This is perfect what we're talking about today.
Can you drop the link, Nelson? I couldn't agree more. Do you have a link you could send us so we can email out?
I'm gonna make something up because I'm logged in through my own membership account, but I'm gonna go ahead and get this together and drop it in a Zoom
And
real
treat
quick.
it like Netflix. Drop in that passcode.
You got it.
All right.
I dropped in your sessions and you all were really thinking outside the box, and I like that high engagement, and you were taking it very seriously as if you're gonna get $1,000 at the end. So thank you for that high engagement. I don't think you all realize how blessed you are with this whole experience, not necessarily Dr. Burden's experience, but all of these experiences. We were just talking about it. It's gonna be maybe a decade from now that you would be just so like, wow, I can do this. I know a little bit about this. I'm feeling this because of all of these wonderful experiences that you're having. And I'm just truly blessed to see you take advantage and dig deep. I know that Saturday is a hard pull. Trust me, it's a hard pull for all of us. And so I just want to say thank you, thank you, thank you for your diligence and high engagement on these Saturdays, and in particular this today, because this is the first real Saturday we've had that has stretched us the whole length of the time. So today from last year. So thank you so much. Dr. Burden, carry on.
My apologies for that.
No problem, no problem.
Yeah, so I just want to hear some of the ideas. So I don't know if you had group numbers, but
1, 2, 3, 4, and 5.
okay, so we can go in chronological order. Just kind of tell me your ideas, what you guys came up with, and just a little breakdown of it.
I think we were group one. I can't remember, but our group came up with one providing reading and like reading resources for clients at bibliotherapy, and then moving them into a space of possible mentorship or pairing them with in an entrepreneurial space with rappers or previously incarcerated persons who had already had that experience and then had become successful, like you know, people in the community like T.I. or, you know, Jay-Z, just anybody who has already like, you know, removed all the barriers for themselves and knows how to remove those barriers and go through that space. And connecting people as well as like teaching them, you know, connecting with possible GED programs or showing previously incarcerated persons how to navigate life if they don't like to be in this space. Like they need to be successful financially, but they may not be able to get a job and need to reconnect in a way that they don't have to work under somebody else. So
Mm.
Oh, that's awesome. Yeah, I'm just trying to think about the two dudes in there because they take a lot of the books out of the jail. It's really disheartening when you hear the inmates say we don't have anything to read.
Mhm.
The only book in the county jails that they're allowed are the Quran and the Bible.
Oh,
You know,
wow.
so just the reinstitute books in the county jails will be an awesome win.
Wow.
And bibliotherapy on top of that, I think would be great. And then, you know, meeting up with those rappers and stuff, I think that would be awesome if you can get commitments from, some of our local heroes to assist in that. I think that would be awesome. But yeah, no books in the jail. That's kind of crazy, but
And
um,
that's unfortunate too, because a large part of incarceration and recidivism is literacy rates. Like a lot of the people that are incarcerated cannot read. So the fact that those are the only two options, of course, they have iPads and they can send emails and things like that, but I didn't know that books were removed from the jails. I did
they're
not.
removed. A lot of people will sneak and contraband in with them. So maybe cut the inside of the book and try to sneak a knife in or try to sneak weed in or stuff like that. So it got too problematic and they just stopped it.
Because we also discussed like audiobooks being an option, but I also, like, could it be Kindle? Could it like it just seems it's a very wild concept that they don't have books to me, or even with it being a digital age, it doesn't have to be a physical book. But considering that a lot of people can't read, how are they even reinforcing them
Do
to be
have the
able to
iPad,
read
they
and
do
go
have
get a job,
pads in there. Yeah. Yeah, Christina, like I said, it's disturbing. It reminds me of like slaves. Like they would try to keep them ignorant where you would get lashed for trying to read. It kind of puts me in the same mind state as that type of mentality. Okay. Group two.
Right. Well, okay. One thing
Sorry.
before we move to group two, one thing that I was really excited about when we talked in our group from group one was attention to STEM. So a lot of times, and I know at least for like people that are a part of the street life, you have to be very good at mathematics. You have to be very understanding of certain chemicals and science. So really honing in on that and trying to build upon that would be something that I would be very interested in seeing how we could possibly then partner with those rappers and other schools systems to see how we could bridge something to enrich that rather than throw that to the left.
A program called West Side Works. It's right. It's not too far from CAU. Down Ralph D. Abernathy. They provide a lot of job training, STEM, CDLs, whatever you want to do at West Side Works. So to couple with something like that can come in and teach, science, technology, engineering, that would be good. But yeah.
Now, Dr. Burden, before we go to group two, is jail 365 days or less?
No, you have some guys in there waiting on trial for 3 years.
Okay.
This is very unfortunate. And then with this new cash bill bond, thing that I was talking about, people may be in jail for a year for something as simple as a traffic violation because they can't afford a bond.
You just had me thinking about like why they wouldn't have books and I was wondering if it was because they feel like people aren't there for long periods of time, but I guess that's not the case. Okay.
Yeah, I
Okay.
think they should have books.
Yeah. Good ideas in the notes, group one. Thanks for sharing. Group two, y'all ready?
What group
Who
were we
represent
in? Were
group
we
two?
group two?
So group two is Bobby, Brianna, Brittany, Kiana, Lashanika. Did I say that right?
LaShanika.
LaShanika, what y'all talk about?
So we had thought about a like readmittance risk assessment. So when people normally, like even when our clients leave us, you're supposed to provide them with resources to make sure that they stay on the right track, to make sure that they keep up with the things that you've learned in therapy. However, in the jail system, they should have the same system, just making sure that once they leave, they have resources and things of that nature. But in the event that they do, are readmitted or do have to go back to prison before depending on what they're going back for, before they go back, just asking, like doing a risk assessment, like, were you given these resources? Were you aware that this was this? Were you able to do this and this? Because most of the time, like we said before, the readmittance to prison or jail, the jail system, is simply because they just didn't have the resources. Nobody tried to help them. So making sure like, hey, if you didn't receive this help, can we try to give you this help before we put you right back in the same place? Because it may not be beneficial, or you may just have not had an opportunity. So just doing something as simple as a risk assessment to make sure that they're getting the needs and what their needs are.
Sounds like it'll be something you have to kind of talk with the courts about to see, okay, in lieu of prison time, we want to do this reassessment to see where we lost them. So can we, intercept them into this program opposed to sending them back to jail? That's good. And then that'll be also good for like those who are doing research. I don't know if any of you want to go into research, after you graduate, but that sounds like a great research topic to kind of understand, some of the gaps in resources and, after incarceration. Anybody want to go and get their doctorate? All right, Nelson, Brittany, Deisha, there's a few of you. Deja, that's cool. Andrea, nice. All right, so a readmittance reassessment. I like that. Number 3, group 3.
So, if you were to think of a halfway house idea, what would you name it? Because you know how sometimes if you name a program something that kind of has like a negative stigma, um, people don't want to join it. So, because our idea was to do a halfway house where, like, even though there would be bunk beds or something like that, where it could remind you of a pretty prison setting. However, at least you have a home to go to where you don't have to go back to jail or prison, or you don't have to be on the streets homeless, because a lot of times that is what stops people from even trying to do better, is they don't have a place to go to.
Mm-hmm.
So like, how would you name that?
Why would it be a halfway house? Is it for people getting out or the people?
Only because like when I'm around people, they mention halfway house where like they could still go in society, but at least they have a place to stay. But it would be more so like you are out, you are free to go, you can still check in with your PO and stuff like that, but giving them a home to actually call a home, where
Mm-hmm.
you can like have an address just to get mail, or you can have an address to tell your employer, or where people can find you. I just don't like know what to call it, because that's my future goal. So that's why I don't know what to call it, basically.
So I mean, it's just like naming a baby. There's power in the name. So you're gonna
Yeah,
just take time and find that name. In the meantime, you can work on employers who will be willing to, give your guys or women a chance. A
So
lot of people don't like to hire felons or
we
convicted
actually,
felons. And so doing the footwork to, find those networks and hiring places for them. Yeah.
yeah, for men and women.
So it's gonna be co-ed. So you have to, make sure that people are safe in there, Yeah, co-ed dorm could be good. It could be a nice community if
Oh no, I need to separate the men and the women. They need their own building because sometimes that might be
Right.
like
Yeah,
something.
you
Like
separate
it could be
Sexual relation.
kind of contradicting
babies
or
and
just detrimental.
all
Yeah,
kinds.
yeah, just too much.
You have to
So
have a daycare for long.
the goal of the discussion, and I think Deja was going to try to put in as well, the goal of the discussion that we had was basically calling it like rehoming. And
Rehoming.
in that rehoming, which Mrs. Campbell, she pointed out, because she put a little laughter with it, and it gave us that reminder of that affection that we have when we need to rehome our pets. And so how I began that process is that when they walk out of that federal penitentiary or whatever type of space, they can't walk out onto the street. They need to walk into another setting. And so that other setting would then include just like an immediate introduction to re-engaging in society. They would definitely have like a living space. It would probably be shared with someone of the same gender. They would learn in that space how to reconnect with another person again. Just from a basic level, we would then also bring in career counselors as well as having clinical counselors and social workers there to not only provide the ongoing mental health support, but now we got to help you to get a bank account. Now we can direct you to companies that are willing to work with individuals that have records that require some expunging. We are now, when it's not just okay, you're out, you're living someplace and you're reconnecting. It's now you've gotten out. This is how we are helping you to reconnect because the plan is in place for after a certain period of time. Now you'll go ahead and be fully independent on your own. So there's a plan that'll be put in place. It would be understood that this is counseling is involved, career counseling is involved, dietary stuff is involved, learning how to look for an apartment. These are things that are now involved. And we also pointed out how if a person is in prison for longer than 5 years, everything has changed. Every system has changed. So now you've got to re-educate. You've got to update them with certain systems, even certain language. So it would be as comprehensive as possible. You can't dot every I and cross every T when it comes to human need, but we would do the best that we can to make sure that they can reintegrate successfully.
Awesome. Yeah, when you talk about 5 years, man, I think about 5 years ago, we would be, in one of the classrooms at CAU. This environment wouldn't be an idea, to meet here on a Zoom call, for the meeting, it wouldn't even be an idea. Good.
Excuse me. And as I was thinking about, I was in the group as well, in group 3. I'm thinking about, we didn't talk about the duration of the program because there's always like a duration when you're in therapy. Are you going to be in for 3 to 6 months or 6 to 12 months? Or what's the maximum duration until they can not age out, well, until they, I guess, come back to the quote unquote of being normal. So that was just my thought that just came out after Nelson started talking, and I was like, we didn't really talk about the duration. Can they stay in there for like 2 years or 5 years max? Because I know the funds that you get from the government is only so limited, and you have to write these grants, and you have to be very specific and detail oriented, and that's just my 2 cents of what I was thinking
Reminds me
about.
of the City of Refuge. I don't know if you've ever heard of the City of Refuge. It's off of Hollowell, not Hollowell, Howell Mill.
Oh,
You
yeah.
know, it's off of Joseph E. Boone
Joseph E. Boone,
on
there you
Old
go.
Simpson Road.
Joseph E. Boone. It's over there because I love their breakfast time. Um, they have a great program, and sometimes women stay there a little more than 2 years, and then they have another housing complex that's right across the street that they house a lot of their former women attendees. But they have so many programs through there. I actually send my children over there for summer camp. And they enjoy it. They welcome all walks of life. So yeah, the time period, I guess it's just it's individualized. People don't recover the same. People don't adjust the same, and you just make those adjustments for different people, you know. But to say you got 6 months to get it all together, I don't think it's that simple, you know. That's an excellent idea. But yeah, I think if you can look at City of Refuge, that's a great model for you to kind of
It's
emulate.
like community.
Mm-hmm.
It's like the whole community.
Sure is.
I've fallen in love with it. I wrote in the chat, I'm in a rotation where it's like 6 of us and we teach a yoga session once a week. And it's really just trying to provide wellness for the women in the community. Something to get out. I love it.
I think their focus is women who may have been sex trafficked or SUDS, substance abuse use disorders. Yeah.
Did we do group 4, group 5? I'm sorry.
Group 4 and
I'm
5.
sorry. One more question, Dr. Burden. What was the name that you said? Community of Hope?
City of Refuge.
Okay, City of Refuge. Thank you.
Mm-hmm. Group 4.
All right, so we were group 4. So the idea that we had was an individualized re-entry planning for each inmate. Because sometimes when they just go out, they're just left to just go out, and they can do whatever. So we establish an individualized re-entry plan for each inmate, which can include identifying stable housing, employment opportunities, access to healthcare, social services, and some type of ongoing support like case management. I feel like that can definitely help them not get back into the system instead of just releasing them and having them to fend for themselves.
I like that. Yeah, maybe if they had a 3-month sentence, you know, around the second month or the end of the second month, you can pull them in for their first reentry session. Identify goals. If you have some houses, apartment complexes, or something that's willing to take some of your people, they can be forewarned, you know, and let you know of their availability and things of that nature. Yeah, healthcare, setting them up. Oh, that's great. You can contract with some employers who will be interested to say, yeah, we'll hire him. You know, here's the stuff. When he gets out, tell him to give us a call. That's awesome. Individualized reentry. I like that. Group 5.
Yeah. Hi. You guys are gonna hear Serenity. I'm sorry. So I have my cameras off. I can't open the honey for you, okay, baby? You can't eat that. I'm gonna fix you some lunch. But we talked about kind of like what everybody was saying, but for me, hold on. We talked about because 2 of us in our group worked at homeless shelters. So a lot of us deal with a lot of our clients coming in from the prison system and the jail system. And we all said that therapeutic services and wraparound services would be the solution. So receiving, and I know from personal experience and professional experience that therapeutic services and wraparound services are a solution as well. Here you go. Oh, you want something else? That therapeutic services and wraparound services are a solution. I talked about my uncle who did 10 years in federal prison, where he attended therapeutic services in prison and then came home to what we call a halfway house. And then I said he got his CDL after he got out, and he was hired by the garbage company as a garbage truck driver, and he lives a pretty good life and he still attends therapeutic services. I also talked about a client that we had at the Cub that passed away in Fulton County Jail. And we talked about how crisis, like how you were talking about in your in talking to us and saying that you rendered education to the policemen and things like that and talk to them about how to handle people in a mental health crisis. So we talked about that as a solution as well, because we were talking about, and we also talked about how the mayor is trying to implement a lot of new initiatives for mental health services in order to combat homelessness, because that's what it goes into as well. It's all systemic and all plays a part. Each arm reaches another. So we were talking about how mental health specifically in therapeutic services should be given in there, but it should be bulked up. And then when they come out, it should be also rendered as services with wraparound services to education, healthcare, job training, of course, a place to live with Maslow's theory of hierarchy, a place to eat and things like that. So it was kind of a combination of what everybody said. But the bibliotherapy was specifically interesting to me, with Katie with group 1 said.
Yeah, thank you. Yeah, those are great ideas. And it's good to hear that success story with her family member and being able to get the CDLs, and still participating in therapy, not neglecting that. And so, I think wraparound services are great. I think you just can't stop the counseling once they leave the setting. We have to kind of ensure that they stay engaged, so that it can be truly effective. This was great. This was great. I took good note of this. I believe there are some assignments or, like reflective things you have to do about this session. So hopefully you have some things to kind of chew on, in
I
the
think you got one
meantime.
more question, Dr. Burden.
Yes.
Okay.
Miss Smith raised her hand.
I just wanted to say that your knowledge and your experience really reminded me of Khalif Browder's story, and the fact that he was in jail, he wasn't in prison, and all of the different factors that led up ultimately to his death by suicide, and just all of the things that affected him. So I feel like like throughout the whole discussion today, I just kept thinking of Khalif Browder. He had, prior to him going to jail, he was in foster care, all the systemic things that he endured, him going to jail, based off of, a charge that could, most, I don't want to say most likely didn't happen, but it could not have been proven.
Book bag.
Yeah, the book bag, it could, it wasn't even proven to be his. So I just think everything we talked about, his story is not a case study, it's a real life story, but I think his story reflects everything we talked about today. So I don't know, it just really resonated with me, and I appreciate everything you shared with us.
You get a lot of cases like that. Like I said, I work in a county jail. I don't work in a prison. So in terms of prison, a lot of times they've been convicted or found guilty. In the jail setting, you have people who haven't been found guilty but are treated as such, and that's where it can become disheartening, you know, especially 6 months later when the charges were dropped, and now that person has to find a new job, new place to stay, because there's no, it's like, oh, my bad. We had the wrong person. That's all you get. There's nothing that comes with that. No checkbook or anything.
Dr. Burden, I wanted to ask before we get ready to close, as a person of faith, and then as a school of faith, Clark Atlanta University, as many of us who are persons of faith, how do we bring our faith to the table when it comes to the challenge of looking at someone that looks just like us and they are in this compounded, restricted system? Because we know their families are praying and we know everybody's praying and everybody's believing, and it can be exhausting. So what would you say so that we don't lose sight, so that we do know that the power of faith, as the scripture says, will save the sick and the sick will recover? How do we hold on to that from a clinical and from a spiritual perspective?
Well, that's a good question. First of all, I have to pray before I go in there. Before I even walk into that environment, I try to cover myself, in the word, and then, have God cover me. And then I kind of instill that hope in them, not to give up. and to reassure him that he's here too, you just have to set your mind on it, and don't be discouraged. I try to remind them that, this isn't the end. It may seem like it, but this isn't the end of the road for you, and to be hopeful and faithful that God is going to make a way. A lot of times I try to integrate spirituality into my counseling if they open the door for it, much like, some of the techniques you've probably been taught in class. But I also try to be an example or a model. I'm not necessarily preaching it, but I like to be that light on the hill, that they can recognize and see. Like, it's something about Dr. Burden. I don't know what it is, but it's something about him that's good, something about him that's righteous. So I try to be that example to them. And it's non-judgmental. I think a lot of times we as Christians I'm a Christian, we can be seemingly very judgmental, to lifestyles and decisions that we probably wouldn't have made, and to be non-judgmental.
Welcome to Wells Fargo.
Someone unmuted. But yeah, I try to prove non-judgmental and understanding. I may not have made the decision that they made, but I try to understand their perspective, And so empathy goes a long way, just trying to walk in their shoes. And, that's when you can really kind of understand their struggle. If you can really be able to display empathy for the clients that you serve in that setting. I think it gives you it gives you a perspective where you can then go to your creator, you can then go to God and say, okay, well, I see what he's going through. I see what he's experiencing, Lord, and you can then come beside that person and walk with them once you understand what they're going through. So being able to be empathic, I think is probably the first part. Like I said, you can get that empathy fatigue, and you yourself can get discouraged, or this is just another one of those, or, and you can really lose sight, that God may be working in this person's life or sat this person down for a little bit to slow them down. It's the only thing that probably could save them. I've had some parents like, are you going to bail them out? No. Let them sit there for a while because, I was too worried about them. I didn't know whether I was going to get a call that they were dead. I'm glad I know where they are now. So just being able to understand, what the person's going through, his family's going through, not losing that empathy.
Thank you.
Mm-hmm. Well, I'm done. Thank y'all. I don't want to hold you up on your Saturday.
I do have one more question, but I couldn't find my hand raising thing.
Okay.
But to get back to the part where, and I know that sometimes prison guards and others, they get fatigued too, and fatigue as well. But I'm wondering, is it more of a culture of how they treat prisoners or those who are in jail? Is it more of a culture, or is it more of the persons themselves? You know what I mean? Because it could be that I could be a great person and I can get a job, to become a prison guard. Or am I taught to treat clients like that? Or, because that's a big part of how we can help them too, because when they're with us, they're okay because we're talking to them like they're real people and, having empathy. But then again, when I leave, like you said earlier, now they got to deal with these people treating them inhumane for the other 23 hours in the day.
There's a lot of time with groupthink. it was a prison experiment done where some of the participants were inmates and the other one were prison guards. And it was like this mentality that the prison guards took on, when they were in that role, that it was very domineering, it was very demonstrative. They were really kind of like really going at the inmates, and the inmates began to start to take on these learned helplessness type attitudes. And so a lot of time it's the group think, what's the culture of the facility? And that's why, I went to educate. I tried to educate the officers and have them understand what mental illness is, so that it wouldn't be, oh, he just crazy, or he just acting off his rocker, da 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 da. He not all the way there, and just labeling people and treating them as such. So if you're in an environment where you've touched bases with the officers that are over the correctional officers, like the lieutenants and things of that nature, if you kind of help them to understand that it's important that we treat these guys like people, and not just a number. Respect them. If everyone's doing it, you're not going to have a person come in and just go against the grain. So it's about creating a culture where the officers are caring or empathetic towards the inmates. But it only takes a couple bad seeds for it to kind of permeate. And I saw that at Fulton, where you had like this green team that would come in and just regulate, and they kind of walked around as if they were like a gang, and would just bum rush cells, and that they rule by fear, you know. And then you're in a population who ain't really scared of you. So what they thought was fearful, you had other guys like, man, if y'all don't sit y'all pump behind down, if y'all didn't have those, y'all wouldn't be nothing. And then you just have this turmoil in there, going on between those who ain't really scared of anything and those who are trying to perpetrate fear. So it was just a real hostile environment, and so I think it works from the top down to ensure that you're hiring officers who, like you said, aren't just trying to um, pay a bill, but those who really have a vested interest in working with this population and helping this population. So I think it starts at the interviewing process. What kind of gentlemen are they bringing in, or women are they bringing in to be officers in these facilities? Mhm. You have women that would be just as mad. It would be so emasculating to hear how some of the women officers would talk to some of the men. I was like, oh man, just take away all of his power, why don't you? And just call him, just belittle him so much. I'm like, man, you know, that's kind of tough. Well, Dr. Giddens, I think that's, I see people eating and stuff, I'm starting to make me hungry right here.
I'm just having a Black History moment. I'm sorry, y'all. It is Black History Month.
It is.
Go ahead and take us to church, Dr. Giddens.
I'm good.
I guess this is your attendance.
If you can, go ahead and do your required survey for this session. That way you won't have to forget to do it later. And make sure that you get those reflections in, so we can review those and we can have those for our reports.
So your reflections aren't due for 3 weeks, so you have time to incorporate them into your spaces over the next 3 weeks.
If we can't scan that code, are we gonna get an email with it?
Yeah, and I'm about to put the actual link. I thought I had it up, but let's see. Do I have it up? Okay, yeah. Let me.
All right. Thank you, Ms. Campbell, for putting up the QR code.
I'm gonna put the link in the chat.
Okay. Thank you, amazing scholars, for attending and engaging, submitting those reflection papers. It'll be probably a great conversation to have somewhere within your practicum with your supervisor, or even with your colleagues that may not be a part of the CI's program, which is what this kind of conversation looks like. I think it resonated with a lot of different things. So thank you, thank you, thank you. And
I have
then
one more question. I don't know if I should stay behind for it while we're closing out.
go ahead, Christina.
So Dr. Burden, I start my high school internship next semester. And I think like I just thought about, I'll probably have some students that are either maybe have been in the system or juvenile, I don't know if the term is like being incarcerated at a young age. Do you have any tips on things to consider when working with high school students as a school counselor, like things that may be beneficial, or just any tips as I enter that space? Because with elementary and middle, it wasn't as prevalent, but I would imagine for high school, I'll see it a little bit more.
This could be it could be very traumatizing to be in a jail setting or juvenile detention center. So I will assess to see if there's any trauma that might be lingering from their experience in there. What have they learned? Being that you're going to be seeing them in a civilian setting, what did you learn from the experience? So just kind of getting a person-centered idea of their experience in that setting, and that they're learning things from that experience. Because experience is the best teacher. So you don't want to shame them about that experience, but kind of utilize that experience as a learning tool and something that you can build on, and when establishing that therapeutic relationship with them. So yeah, but first is asking the question, to kind of to get whether or not they have or not, and then going with them, to that experience and helping them revisit that experience, because it's something they're probably not too proud of, or wouldn't be anything they'll bring up willingly. So just walking with them through that experience and helping them to process that experience. Because at that age, it probably stands out to them as like, I messed up, man. I had to go to this, that, and the other, And so you can probably get a lot of data, for lack of a better term, from the child, if you just help walk with them through that experience.
Thank
you. Mm-hmm.
Good information. Did anybody else have any closeouts, questions, or comments? Ms. Campbell, did you have anything else you wanted to share?
No, just thank you all for being really engaged today. Hope you enjoyed the session. Shout outs to those of you who came and participated in our last session in person. Do you want me to share that now, Dr. Jones, or you want me to?
Sure, absolutely. I love it. Ms. Campbell is very creative.
What are we sharing?
Ms. Campbell, go ahead. You got it.
Okay.
Jones got separated. There he is.
Did you share it? I saw the beginning of it. Uh-oh. Did I lose y'all?
Uh-oh.
We're here.
Hold on, let me see.
We're here.
Okay, here we go. All right, just a little shout out for those who came out and participated in our vision board session. We had a really good time. Hopefully you got a lot out of that. Everyone got a book from our speaker and author, Miss Tracy Leaks. So I just wanted to share this and give you guys a little shout out.
How fantastic. Thank you, thank you, thank you.
Yes, and please, if you can, try to come to those in-person sessions. It really is beneficial to you all to get to know each other and get to know us. And then that just makes it easier and better for you guys to participate in these sessions when you're more comfortable with who's in our group, okay?
Yep. We're working on trying to have a nice closeout session for you in May. So hopefully, I think Ms. Campbell shared a calendar of events with you, and that probably is in our announcements in Canvas. But we love it. And so yes to all the things Ms. Campbell said. And hopefully she's been reaching out to, I know we had that session with Mr. Charles Johnson, was that in October, maybe November? But he had mentioned an opportunity for possibly an in-person connection for maternal Black health. Ms. Campbell's working on that. So we're trying to have as many of our in-person sessions or hybrid sessions as we can to kind of go along with these virtual sessions. So we appreciate your work and engagement. And yeah, thanks for sticking with us. You got any final thoughts, Dr. Giddens? Any shout outs, comments?
No, just want to thank Dr. Burden for his wonderful presentation today.
Yes.
And we hope you have a great weekend, and you may receive an invite for our final event at the end of the year.
We love it.
That'd be great.
We would love it. We love it. We love it. Because it's similar to some of our students, we don't see them until like at the end of the semester in person. So it'd be nice to be able to touch a person that we actually had a session with. That'd be great.
Yeah, that would be awesome.
Yeah. Thanks, Ms. Campbell, for recommending Dr. Burden. This was definitely great and informative. We don't want to hold you. I hope you enjoy the rest of your Saturday. On a closeout, anybody know what the first song Usher gonna sing tomorrow is? I think I know.
It's 7 o'clock on the dot. I'm
in my drop top, cruising the streets.
Yeah.
That's what I was gonna say. Yeah.
Daddy home once again. Can you tell I am so juiced up? Like this 16 minutes cannot
Me
come
too.
fast enough. It cannot come fast enough.
I would love it if he can play Confessions, but he probably won't play that.
I'm in the studio.
Have a great Saturday, everybody.
Bye. Have a great
Have a good one, y'all. Take care.
Have a good one.
Take care. See you next time.
Bye.